All right, everybody. Thank you so much for joining us. Welcome to this partnered webinar. PeDRA is proud to be partnering with the National Foundation for Ectodermal Dysplasias on this talk, Dermatological Manifestations of Ectodermal Dysplasias and Patient Case Presentation. Next slide. Just a brief overview of our agenda. We have a lot to get through this evening, and this is what you can look forward to. Next. With that, I am going to turn it over to Becky from National Foundation for Ectodermal Dysplasias to introduce our speakers.
Thank you so much, Jen. This is the list of speakers that we have today. And since we have a very full agenda, we're going to get started right away. So I'm honored to introduce Dr. Elaine Siegfried. She's a professor of pediatrics and dermatology at St. Louis University School of Medicine. So go ahead, Elaine. Thank you.
And thanks everybody for attending and for your interest in the ectodermal dysplasias. I just want to give you a little background. I've been involved on the scientific advisory board for the National Foundation of Ectodermal Dysplasias, gosh, for at least 25 years, huh, Mary? The 30th anniversary was just celebrated. It's a wonderful organization, and the amount of effort and really reward of investment from the NFED into, better treatments and enhanced understanding of this group of diseases has just grown by leaps and bounds, and it couldn't have been done without the NFED. So for any of you who are interested in the NFED, please, consult the website. I'm sure Mary would be happy to talk to you, and, we're always looking for people who are interested in helping us with the mission. So today I'm just going to give you a little overview that is really based on, again, these 25 years of experience of, having the privilege really of meeting with so many families with ectodermal dysplasias, particularly at the annual family conference. And then we had some wonderful sponsored AEC conferences. It allowed me to meet and interact with so many more people with this group of conditions than I ever would have in the office. So I'm just very privileged to have had that experience, and I can speak to you a little bit about that today. It doesn't look like I can advance the slide, so I guess I'll just say next unless I'm missing how to do it. So it just has a little simple overview. We're going to talk a little bit about diagnostic issues related to ectodermal dysplasias, and then talk a little bit about treatment. Next slide. Diagnosis first. So the most common ectodermal dysplasias, I'm sure most people who are attending the conference today know, is the hypohidrotic ectodermal dysplasia. So the majority of those have X-linked. It occurs in about a frequency about 1 in 100,000 males, but there's also autosomal dominant and autosomal recessive forms. The X-linked form works through the receptor, and the dominant and the recessive forms the X-linked form works through the protein, and the dominant and recessive form work through the receptor. You're all aware that the presentation, it typically in early infancy begins with this impaired ability to sweat, hypohidrosis, that then in turn causes hyperthermia. So affected babies, in addition to having a really somewhat characteristic facial features, which I'll show you some pictures of, they typically have a history of presenting with recurrent fevers of unknown origin. In infancy and then beyond, they are plagued by a variety of related problems like thick nasal secretions and thick cerumen, xerostomia and xerophthalmia, and then, the aesthetic features of the condition. Another real characteristic feature is hypodontia, and then these very characteristic conical teeth. And then dermatologic signs, there are many, but the biggest challenge comes in infancy. So from a dermatologist perspective, what do we see? Often kids will present with collodion phenotype, although not always. They have very dry skin. As they get older, and especially at adolescence and beyond, they have this really characteristic sebaceous hyperplasia. We know from work done by the NFED that atopic dermatitis is more common in this population. Then there's also that characteristic periorbital and infraorbital darkening and wrinkling. I'll show you some pictures of that. That's an aesthetic concern for some people. Fine, sparse scalp hair is another aesthetic concern. And interestingly, although males have early onset androgenetic alopecia, conversely, they just have this really abundant male beard for reasons we don't really understand very well. Nails can be thin, and the dermatoglyphics are often attenuated. Next slide. These are just some illustrations of some pretty characteristic features. You can see, I don't know if you can see my pointer, but I'll show it to you here. These, very characteristic conical teeth. And many children who don't present with recurrent fevers of unknown origin will get their diagnosis, from their dental healthcare professional because of their conical teeth. This is a picture of some very marked sebaceous hyperplasia. Lips tend to be very full. You can see the periorbital darkening. Again, an adult who's got both the conical teeth, but markedly, sparse hair, and again, starts early on in adolescence, but, by contrast, really thick beards. Don't understand why that is. It just is. Next slide. This is a really old picture from Jenna Seibert. Jenna's also been participating longer than me in the National Foundation for Ectodermal Dysplasia Scientific Advisory Board. And just as a historical mention, Nan Esterly was the very first dermatologist to participate. But this is a picture from Jenna's collection, just looking at, noticing the attenuated dermatoglyphics in this affected patient versus a normal control. Little kids with ectodermal dysplasia, cute. They tend to have, again, fair skin, very fine, sparse hair, and you can see this guy's little bitty conical tooth. But sometimes it's just, and you can also begin to see a little bit of that periorbital darkening. So the facial features, while they're subtle, are pretty characteristic of hypohidrotic ectodermal dysplasia in this affected boy. But sometimes it can just be subtle and can be easily overlooked. Next slide. So this is the real challenge. So this is a newborn, again with the periorbital darkening, very sparse hair, scaly skin, and this is a sort of typical presentation of a newborn with hypohidrotic ectodermal dysplasia. Next slide. That it used to be much more of a challenge to make this diagnosis, but genetic testing is now widely available commercially and is much more affordable than it used to be. My favorite place is probably in Fete, but there are other places that you can get genetic testing, and the NFED has a repository for that kind of information. The genetic testing results can be delayed, although they're getting faster and faster all the time. And previously, prenatal testing was only available for families who had an identifiable mutation, but now you really can get genetic testing pretty easily. So, establishing the diagnosis is not nearly as hard as it used to be. Next slide. But I did want to give you just a historic overview of some of the projects that have been funded by the NFED. And way back at our 2001 NFED Family Conference, seems like yesterday to me, but it was already more than 20 years ago, we looked for other methods of making a diagnosis beyond genetic testing because that was so unaffordable and difficult for finding access. So we at the Family Conference, which was in St. Louis that year, and tragically, in the middle of St. Louis, in the middle of the summertime in St. Louis, where the weather was, 90 degrees, the air conditioning at our hotel went out. I've never seen a hotel swimming pool so full of all those kids with HED. But we had many, many volunteers, both affected individuals and carrier relatives, as well as unaffected relatives. And next slide. So what we did was we tried to characterize the condition based on the results of some skin biopsies. And we did both the scalp and the palm just to look to see if we could quantify the number of both hair follicles and eccrine glands. And what we found was that even though the palm kind of occurred to me that it might be a little bit better place to test, it was really the scalp that was the much more sensitive place. Sweat glands are much more dense on the palm, and people with HED can have sweat glands both on the palm and the scalp. It's just that you can see the difference a lot better on the scalp. So that was a cute little study that we did before we had access to such great genetic testing. Next slide. There's many other diagnostic challenges in the ectodermal dysplasia category, so I'm going to talk a little bit about that. Ectodermal dysplasia with immune deficiency is due to a mutation in NEMO that really is very similar, really a dead ringer for hypohidrotic ectodermal dysplasia due to ectodysplasia defect. And this condition is actually allelic to incontinentia pigmenti, so affected boys who survive. Yeah, because a lot of boys don't survive with this mutation, but the boys that do survive often will have sisters who have incontinentia pigmenti. And their clinical features, as I mentioned, are very similar to this X-linked HED, except that they also have recurrent severe life-threatening bacterial infections with strep pneumoniae, Klebsiella, and especially atypical mycobacterium that can progress to chronic lung disease. They often will have failure to thrive with chronic diarrhea. So this is a tragic condition. I actually had one patient that that we lost due to this condition, but it's very rare. Next slide. This is that little boy. He's been gone for quite a while now. The other thing that's important to be aware of for kids who have this condition is that they probably have impaired barrier function, and so they can really, they're at really risk for excessive percutaneous absorption and percutaneous toxicity to products that you use on their skin. Yeah, he got older, but he died of overwhelming infection ultimately. Moving on to hydrotic ectodermal dysplasia, or Clouston syndrome. Sorry, they don't skip over that one, which is a type of ectodermal dysplasia, but not really related to hypohidrotic ectodermal dysplasia. And these are some of the characteristic features: palmoplantar keratoderma, sparse hair, again, just like we see in HED, and then also very characteristic nail findings that I think can really make that diagnosis. Nails are hyper curved, and you can see this kind of very bizarre hyperkeratosis at the tips of the fingernails. Next slide. Kidd syndrome is another one that is, the phenotypic presentation is very diagnostic, and although this condition is very rare, it's been classically described, and I've seen this just anecdotally in the same way. When children are born, the description is that they're covered with thick vernix. And so in this particular case, the kid that you see here pictured on the left is a child who the neonatologist called me up and he just said, "I've never seen anything like this before." I'm like, "Well, tell me what you're seeing." This was in the days before we could put pictures into the chart. He said, "They're just covered with thick vernix." And again, that's been described in the literature. They also have very characteristic, I think it's on the next slide. If you flip there, nope, go back to the last slide. They have very characteristic, almost stippled palmoplantar keratoderma as well, that you can make a diagnosis. And then, of course, it's indicated to do a, brainstem auditory evoked response, or, begin with doing hearing screening. And often, these children also suffer from severe immune deficiency. A subset of them can, and have maybe a shortened life expectancy. Next slide. Then we're going to move on to beyond the hypohidrotic ectodermal dysplasias and the rarer variants of ectodermal dysplasia onto the P63 group. And historically, these always were referred to as different conditions based on some of the distinguishing features. So AEC, or Hay-Wells syndrome, featured ankyloblepharon. EEC syndrome featured ectrodactyly, and Rapp-Hodgkin syndrome featured this kind of characteristic mid-face hypoplasia. But we know that there are some families that children are born to the same families that have a Rapp-Hodgkin phenotype and an AEC phenotype. So, these are all mutations in P63, and there's some genotype-phenotype correlation with the location of the mutation, but there's also quite a bit of overlap with these conditions. This is just the case that I mentioned that was reported, where a mom who had a Rapp-Hodgkin phenotype had a child who had more of a EEC phenotype. The dermatologic features of this condition are also really distinctive. And the biggest and most problematic is that they have very severe congenital erythroderma, and often accompanied by severe erosions in 90% of patients. The most common place for those erosions is the scalp, but they can cover, you know, a large percentage of body surface area. Often there's a collodion-like phenotype, chronic ichthyosiform scaling, and again, the kind of characteristic sparse hair that we see in other forms of ectodermal dysplasias, but, you know, it's brittle and can feature pili-torti. And the nail dystrophy that occurs is described as, you know, small and thick, hyperconvex nails. Heat intolerance is not as common as it is for the HEDs, but it occurs in about 50% of patients. And again, the scalp erosions that are prominent in the newborn period can be chronic, but typically do tend to improve over time. The NFED funded a wonderful conference in 2006 that focused specifically on AEC and to try to get some sort of group consensus about the diagnosis and, you know, how to really best take care of these patients. And so, you know, it was concluded at that time that recognition of the distinctive congenital features, you know, is really important to minimize unnecessary invasive diagnostic testing. And the features are just listed here as we've mentioned, but particularly the erosions, the skin erosions are very problematic, but also very characteristic of the condition. How do you treat it? Well, in the 2006 consensus meeting, we came up with some very conservative approaches because nothing had been at all described before that. So if you flip to the next slide, you can see what the oh, sorry, it's just a summary, and then we'll get to the recommendations. But you know what? Sorry, I'm wrong. I'm going to get to the AEC recommendations only at the end of the study. We're just going to talk a little bit about recommendations just for ectodermal dysplasias in general. And these are things that, you know, all dermatologists are really aware of, but just to briefly go over this, and these are some of the things I think it's important to provide anticipatory guidance about that. You know, daily bathing, gentle cleansing, very similar to skincare that you would do for children with other kinds of inflammatory skin diseases. Avoid complex topical products. We like plain petroleum jelly. Coconut oil is a good second. Next slide. Specifically for ectodermal dysplasia, you know, children may prefer less occlusive creams or lotions, especially in summer, and their skin is not quite as sensitive as those who have just pure atopic dermatitis, unless, of course, it's a child with HED who does have atopic dermatitis, you know, in addition to their ectodermal dysplasia. I always say that swimming is an ideal activity for children with ED, with any kind of ED who has hypohidrosis, you know, because the cool water really reduces the body heat. Having said that, there's lots and lots of kids who come to the family conference in the summer that do all kinds of things, from playing soccer to running marathons, and they tend to really tolerate that. We'll talk a little bit about controlling overheating here in a minute. But, you know, moisturizer, waterproof sunscreen, reapplied when the skin is still wet. For eczema, you know, everybody knows about eczema. There's different recommendations that I have here, really that are directed towards patients more than healthcare providers, but these are some of the things that we try. A little, you know, the FDA just came out with a statement about N-acetylcysteine because it's been a little bit on short supply, but also, you know, we don't really know about the efficacy of it very well. So, you know, you want to use that with caution, especially in very young children. Next slide. Seborrheic dermatitis, also a problem for lots of people with HED, more common in infants presenting as cradle cap. You know, I personally think that this condition is significantly related to malassezia, colonization, and overgrowth. So I often will recommend, you know, medicated anti-dandruff shampoo, or sometimes if it's more severe than that, a 30-minute pre-shampoo type scalp treatment with one of the products that's listed here. And then, you know, there's other topical prescription products that can be used in more severe cases. I always recommend for our patients, you know, to really be aware of the potential for product sensitivity. I'm not a contact dermatitis expert by any means, but I'm an armchair contact dermatitis interested dermatologist. I think it's really an under-recognized condition that can complicate many of the things we see, including the ectodermal dysplasias. I often will recommend a DIY patch testing for people, especially before they're going to try things like sunscreens. Just apply that product to a quarter-sized area inside of the upper inner arm once a day for about 5 days, and then continue to monitor the site for 2 weeks. I recommend this a lot. I have to tell you that not a lot of patients actually follow through on it, but it is a good idea if they would do so. Sun protection, especially for young infants, is much more dependent on shade and sun protective clothing. My favorite sunscreen for babies is just plain zinc oxide ointment, not advertised for this purpose, but really the safest and truly most effective physical blocker that there is. You can tell when it wears off because you can't see it anymore, so that kind of prompts reapplication. For older children and adults, I just, recommend reading the labels, really reading the labels for getting the broadest spectrum of protection, and then knowing about, the substantivity of the vehicle. Next slide. Talk a little bit about hair growth. I have found that there's not that many people with HED, maybe younger kids and early adolescents, are really more concerned about sparse hair and sparse hair types. The adult males, by the time they get to be the age of this guy, they do have thinning hair, especially on top, but again, as I mentioned, a very thick beard. Eyebrows and eyelashes can be fine and sparse as well. Facial, groin, and underarm hair usually develop normally at puberty, there is concern about some androgenic alopecia. Little tips for helping children who have fine sparse hair. I think short styling probably minimizes the appearance of fine short hair. Gentle cleansing products, volumizing conditioners are certainly not problematic or risky for these kids. I think, we've recommended minoxidil for some people who really want to try it. I don't have data about how effective it is. Same thing for Latisse, for eyebrows and eyelashes. But what I often counsel people that have concerns about hair growth in this condition is to be aware of all the unsubstantiated claims that are associated with products that are, talk about supporting hair growth. Same thing for androgenic alopecia. I listed some things here that people are using. I certainly don't have any experience in treating androgenic alopecia in adult men with hypohidrotic ectodermal dysplasia, but just to be aware that the quality of the evidence for pretty much all these products, except for minoxidil, which has pretty robust data, but it just doesn't work all that well. And again, I try to caution people about being wary of unsubstantiated claims. A little bit about nails. Well, as I mentioned, the nail abnormalities with each one of the HEDs is most useful for trying to make a diagnosis because they all have kind of different but relatively characteristic nail findings. People with HED have thin nails. People with Clousson syndrome have thick nails. There's a variety of nail dystrophies that happen in the P63s, and usually they're brittle. And anytime you have brittle nails, you have an increased risk of secondary infection. For thin, fragile nails, there's things that you can recommend, and here's some of the things that are listed. Nail lacquers can just help a little bit the quality for the thin nails. There's orthosalicylic acid, that's BioSil capsules. I don't have any experience with the efficacy of those, but there's literature supporting the use. Biotin supplements, not much literature supporting the use, but it's something that's safe that people can try. And then some people liked the thought of using artificial nails. I don't think that those are contraindicated, but I always do caution people about the risks of irritation or contact allergy. For the thick dystrophic nails, it's really important to have, good fitting footwear. One of the things that people can try is just sequential filing. You can get these, almost sandpaper grid, finer and finer sandpaper grid that people can use to try to thin out their nails. 40% urea, especially under occlusion, is something that people can try, but it's so labor intensive that I certainly don't have many kids that can keep that up. And then you always got to be aware of the possibility of secondary fungal infection. And I like to look, my favorite clue, especially for onychomycosis in the feet is to look for web space scale between the 4th and the 5th digit. I think that's kind of a sensitive sign for tinea pedis, and I don't think you can get onychomycosis unless you got tinea pedis. Other things that are HED specific, the periorbital hyperpigmentation that I mentioned, the sebaceous hyperplasia, collodion phenotype, and for the P63s, the terrible problem of skin fragility, and then, the ongoing ichthyosiform scaling and palmoplantar keratoderma. And we didn't talk very much about Gold syndrome, but Gold syndrome is a condition that's rare, but really has some very difficult to treat dermatologic problems, especially the papillomas. Next slide. These are all therapeutic challenges. So here's even a young girl. I know I showed you pictures of a baby and some older, some adults who have this hyperpigmentation. Mm-hmm. It's really strictly an aesthetic concern, but we don't really know what causes it exactly. But the things that you can recommend are the rub-proof, waterproof, camouflage makeups. There are in-office options that are offered by some cosmetic dermatologists and plastic surgeons that have been mentioned, like chemical peels and microneedling. But again, just like with hair growth products, I really try to counsel people and provide anticipatory guidance about unsubstantiated claims. Sebaceous hyperplasia is a really odd one, especially given that these people have, a dearth of eccrine glands, but their sebaceous glands seem to be, hypertrophied. It's again an aesthetic concern, and people who have hypohidrotic ectodermal dysplasia, they have sebaceous hyperplasia much more than they have problems with acne. There are things that you can try, nothing that's, well proven to make this better. I always would start with a topical retinoid. I think that isotretinoin is another possibility, although I've never used that in anyone with this condition. And then there are in-office procedures that have been mentioned as well, like cryotherapy, electrocautery, and, application of a desiccant like TCA. Collodion baby is another issue. I haven't seen well, I guess I saw a couple of them last year. And of course, that's a phenotype, and there's many genetic conditions that can result in this end-stage phenotype. But in the next slide, it just has, recommendations that are published with how to manage a collodion baby. It's gotten so much better since we now have isolettes where you can dial the humidity in a way without guessing, but you want to start out with a high humidity isolette and then just very gradually dial it down, and first do no harm. So typically we just start with bland emollients like plain old petroleum jelly as you're helping a child, a baby, to adapt to a xeric environment from an aqueous environment. Next slide. We'll talk a little bit about, this was a slide I thought was coming up earlier, but the skin erosions in AEC syndrome and the P63s are a major cause of morbidity in infancy, and we don't have well-established guidelines for how to treat this. It primarily, as I mentioned, affects the scalp, but it can be total body, and that's where it's the most life-threatening. And as the condition progresses in postnatal life, it has associated crusting and granulation tissue and really severe pain that's associated with that. Next slide. At our 2006 conference, we focused on this and to try to come up with anything that we could do as a general standard recommendation. But the problem is chronic, and secondary infection is a big risk, and it definitely heals with scarring, including scarring alopecia. The keratodermas are probably somewhat related to just the erosions, although presenting differently in the palmoplantar skin. You can also get the same kind of features in the ear canal, and again, as I mentioned, they can be quite extensive and painful. So these are the recommendations that were proposed in that 2006 conference. Just again, do no harm, avoid irritants, avoid excessive aggressive debridement that some are wont to do, avoid an attempts at full thickness skin grafting. It just doesn't work very well. So the same kind of gentle skincare techniques that we do for collodion babies, gentle cleansing, bland emollients. You can try using antimicrobials, so dilute sodium sodium hypochlorite soaks. You can get that from Dakin's in the hospital, or Vosh is another product that's more recently available. And then there's a lot of innovative wound care that people have tried. So these are Mepilex Transfer is one product that some people have found useful. And then, with inpatient care, you just always have to be aware of the risk of secondary infection from bacteria, yeast, and even viral infection. So a lot of these kids require extended home nursing. But one of the real lessons that we've learned from some kids who have come to the attention of the NFED is that, you don't want to let the wounds get too wet or too goopy. But I know Shannon's going to have a lot to say about that from her own personal experience. Before we go on to GOLTS, I did want to just very briefly mention that the NFED has been in contact with a group in France that are doing some incredibly exciting work on targeted approaches to helping heal skin that's affected by these P63 defects. So, stay tuned. It's an exciting time for people who have this group of conditions. Just want to mention a little bit about Gold's papillomas. This is a real therapeutic unmet need. It's characterized by squamous proliferation and stromal proliferation. It may, in some cases, be HPV associated. It mostly affects mucosal sites around the mouth and the eyelids and perigenital, and malignant transformation has been reported. We don't really have great treatment, as I mentioned, for GOLTS. Very difficult. In-office procedures have been suggested: cryotherapy, podophyllin, excision, these destructive kind of techniques. Oral cimetidine has been suggested, interferon alpha injections. Certainly prophylaxis with the non-covalent HPV vaccine is something that you should recommend to these patients. I don't know how effective it is with their papillomas, but be aware that even with surgical and destructive techniques, that reoccurrence is common. So that's all I had to say in that little brief overview, and I'm really looking forward to hearing our next guest.
Thank you so much, Elaine. We're going to hold off on questions until the end of the presentation. So I just wanted to introduce a wonderful NFED family, Shannon Brown and her daughter, Erin. And they will tell you a little bit about their journey and diagnosis with AEC, which is a form of ectodermal dysplasia. So Erin and Shannon, take it away.
Hello, I'm Shannon. This is Erin. So in 2011, I found out I was pregnant with my first child. The pregnancy seemed normal until around the third trimester, when I was found to have low amniotic fluid, causing intrauterine growth restriction. Due to this, Erin was born breech via a C-section. It wasn't known until her delivery that she wasn't a typical newborn. She had skin erosions covering approximately 70% of her body and an acleoblepharon of her left eyelid. At the time, they suspected epidermolysis bullosa, and Erin was transferred to Atlanta and admitted to their NICU, where she remained for around 6 weeks. Epidermolysis bullosa was eventually ruled out, and they proceeded with genetic testing to look for a P63 gene mutation. Looking back, it was at this point that I believe the NFED should have been first contacted. As it was, both our family and the NFED were unaware of Erin's suspected condition. During Erin's remaining time in the Georgia NICU, her condition rapidly deteriorated. She was losing fluids through her skin, which affected her platelets and hematocrit, which resulted in 5 blood transfusions. Her erosions, rather than healing, were worsening and covering more of what little completely formed skin she had at birth. The bedding that was used created friction, furthering breaking down her skin. The pulse ox was left in place constantly and created a significant breakdown of the skin on the soles of her feet, and contributed to her delay in walking even more than a year later. Simple things such as gently measuring her head caused bleeding. At this point, our family decided that Erin needed to be transferred to a different care facility. The hospital she was at seemed only to be offering her palliative care, such as morphine and high oxygen chambers. They avoided changing her diaper even when it needed changing because it was so painful to her. They avoided bandages until an area was openly bleeding. This plan of care made us uncomfortable, and we felt there should be a more proactive treatment and family education. We contacted University of Michigan, which was a hospital near where my mom lived, and we we requested a transfer of care. Immediately, in fact, as Erin was en route to the University of Michigan via the airlift helicopter, we found out the hospital had already contacted the NFED in anticipation of caring for Erin, and they had received information on treating and caring for Erin's skin condition, which had now been diagnosed via the genetic testing as AEC. Erin's circumstances were vastly improved with the transfer of care, the diagnosis, and the contribution of the NFED. We were greeted at the hospital by the dermatology team, and they continued to evaluate Erin on an at least daily basis. We found that having dermatology take the lead resulted in a much faster and more comfortable healing process. Our previous experience had consisted of visits from wound care and 2 visits from dermatology over a 6-week period while she was in Atlanta. Before Erin was discharged, we were taught and trained on how to care for Erin's skin. These are some of the things that we learned, some or all of which you may already know, and some that Dr. Siegfried just went over. Do's, we did daily sponge bath with diluted bleach and disposable gauze, performed by gently placing the gauze that had been soaked in dilute bleach over her body, her entire body, and avoiding any wiping, rubbing, or scrubbing. Dressing changes consisted of liberally coating Zeroform with either Vaseline or Aquaphor and then wrapping the affected area. Clothing worn over Zeroform benefited from having Vaseline rubbed into them prior, so as not to let the Zeroform dry out. If the Zeroform dried out too much when you went to do the dressing change, it would tear off more of the skin barrier. Diapers, for diapering, we cut about a 7-inch length of Zeroform coated with additional Vaseline and laid it on the groin and lower back in the diaper prior to diapering. We continued that for, as long as she was in diapers, so around 3 years. Duoderm, always to be used. Tegaderm and similar adhesives caused erosions and irritation. Granulation tissue responded gradually to steroid creams. So what we found did not work was Castile soap. Exposed IVs, if you wrapped the IV, specifically while the child is in the NICU, so the child does not cut themselves on the IV, causing more skin breakdown. Dry gauze on bare skin. Sween or dimethicone-based emollients that didn't work. Tegaderm, chlorhexidine wipes for like surgical placements. She had a Broviac placed, and they were wiping that area down with chlorhexidine. That quickly broke down the skin on her chest. And pulse ox worn continuously. We found the best way to do that was to take the vitals, take the pulse ox off. When the vitals needed to be checked, take the pulse ox or put the pulse ox back on. Dressing changes, bleach baths, really all of the above and often, really all of the above and often more were our daily routine for about 9 months. In summary, we experienced subpar patient care and education at the onset, which resulted in feelings of despair and isolation that we are still healing from. Everything changed when Erin was transferred to a hospital focusing on learning, teaching, and patient care, and so willing to include the NFED. The collaboration of the NFED and Michigan Medicine or University of Michigan saved Erin's life. The NFED has been priceless. We are not alone in seeing similar people not only surviving, but thriving. We've created relationships and learned from one another's mistakes and victories. I really appreciate you taking the time to be here and listen to someone like me who doesn't know all the medical terminology, although now I know a lot more than I'd like to. Your dedication to learning and working with families is exactly what saved my daughter's life. Thank you.
Thank you so much, Shannon, and thank you, Erin, for participating as well. Shannon and Erin are going to stay till the end of the webinar and answer any questions that you may have. So next we have Mary Fete, who is the fearless leader and executive director of the National Foundation for Ectodermal Dysplasias. Take it away, Mary.
Well, good evening, everybody. And first of all, thank you so much for joining us and for your interest in the ectodermal dysplasias. And also thank everybody who's listening to the recording for your interest and learning about the ectodermal dysplasias. You know, before I get started, I just have to say one thing. I've known Erin and Shannon Brown since Erin was born. You will never meet a more fierce mother advocate than Shannon Brown. And I would dare to say you'll never find a tough little girl, a fierce warrior and fighter as Erin. They are amazing, and their strength and courage really humbles me. So I'm really happy to be with you, and I'm excited to tell you just a little bit about the National Foundation for Ectodermal Dysplasias and our role as a patient advocacy group. So our mission is to empower and connect people touched by ectodermal dysplasias through education, support, and research. And you know, we proudly serve more than 9,000 families in 80 plus countries. So although we're housed in the United States, we have families in 80 plus countries. You know, ectodermal dysplasias are rare, occurring in 3 to 7 of every 10,000 births. So that means up to 4 million are living with some form of ectodermal dysplasias worldwide, up to 225,000 in the United States alone. And, you know, the problem with ectodermal dysplasias, and Dr. Siegfried spoke a little bit about this, it's really challenging to diagnose many of the ectodermal dysplasias. So families go years without a diagnosis, which is really problematic. So I won't go over this in detail because Dr. Siegfried did a wonderful job talking about the hair, which can be missing and sparse and abnormal in texture, the teeth. She showed you the conical teeth. Teeth might be missing. Some babies are born, children never develop any teeth, which can really be a treatment challenge for our families. Sweat glands don't work properly, and so children can overheat, and so they have to learn to manage that. Nails, Dr. Siegfried talked about, they can be thin, thick, abnormally shaped or ridged, or they can be missing. And then the skin, Dr. Siegfried went into great detail, so I won't hit on that. So we really pride ourselves in providing accurate information. And as Dr. Siegfried said, we celebrated our 40th anniversary this year, so we take a lot of pride in all the resources and the knowledge that we've developed over 40 years. We have family conferences every year, national conferences where our families gather together to learn from each other and to learn from our experts. We have a kids camp in which kids have an amazing time. It's just so cool to watch these kids come to conference, and they don't want to go to kids camp. And then by the time conference is over, we can't drag them out of kids camp. So it's a wonderful time for them to be with their peers and other kids that look like them and have similar challenges. We have webinars like we're having tonight, and we also sponsor webinars for our families, educational webinars. We have a very robust website, which a plethora of information is on our website. So I would encourage you to check out our website, nfed.org. We have professional education, which can be seminars, workshops, and we do dermatology grand rounds where we bring our families to teach professionals on their challenges. And it's really, truly an amazing event. We provide support for our families. We connect families with other families so they can learn from each other. We are one organization that we personally answer the phone, so you're not going to call the NFED and you're not going to hear press 1 to get this or 2 to get this. You're going to have somebody answer the phone and be connected directly to a support person. We have a First Connect program for our new families. We have family liaisons in various states to support locally. And again, I talked about family conferences, and I think we have like 16 Facebook groups. So we provide a lot of support through Facebook. We have support for treatment. We have the Dental Treatment Centers program where we collaborate and partner with dental schools and private practices to provide quality, cost-effective care for our families. We have a treatment assistance program and an insurance assistance program. In our treatment assistance program, we can help provide dentures for children. We strongly believe that children should be wearing dentures by the time they go to kindergarten. Some as young as 3 years old. These children have been able to wear dentures. We feel it's important for nutrition, for facial symmetry, for chewing and speech. So we strongly encourage our families to advocate for dentures for their children. We provide cooling vests, and a lot of education on how families, parents can keep their children cool so they don't overheat. Many children don't need cooling vests. Some do, but we can help families with that. A lot of families just carry a lot of squirt bottles around and wet t-shirts for sports. We also provide wigs. We help provide wigs for individuals with sparse hair. So we can help with that. And Becky's going to go into a lot of detail about the Ensuring Lasting Smiles Act, but it's our role as a patient advocacy organization to not only support our families, but also to advocate in their behalf. So I'm really proud of our efforts that we've done in regards to ELSA, and I look forward to Becky telling you about our efforts. So we have made a significant research impact. Dr. Siegfried talked a bit about it. We have invested more than $3.6 million in research. I think that's pretty incredible for a small organization such as the NFED. We've sponsored 118 different research studies and trials. We've sponsored 10 research conferences, and our families line up to participate in research whenever there's an opportunity available. So I strongly encourage you to refer your patients to us. We have a lot of resources, both educational and some financial assistance. Follow us on social media. Our website is nfed.org. And I thank you very much for your time and attention. And I will end with that. But please, please, please refer your patients to the NFED. Thank you. And I'll pass it on to Becky.
Thank you so much, Mary. Mine is the last and final presentation, and then we will open it up for Q&A. I'll just quickly introduce myself. I'm Becky Abbot, and I'm the Director of Research and Treatment Advocacy, as well as the co-chair of the NFED Family Driven Advocacy Committee. Not only do I work for the NFED, but my oldest of 3 sons, Aiden, is also affected by XLHED, or X-linked hypohidrotic ectodermal dysplasias. And I'm here to talk a little bit about the Ensuring Lasting Smiles Act. So the Ensuring Lasting Smiles Act, which is also known as ELSA or HR 1916 in the U.S. House of Representatives, or S754 in the U.S. Senate, is federal legislation that was reintroduced last year, March 16th, with strong bipartisan support. As of right now, we have 317 co-sponsors in the House and 42 U.S. Senate co-sponsors. The bill also passed in the U.S. House of Representatives on April 4th of this year with a 310 to 110 vote, which is absolutely amazing considering it is a healthcare bill. So ELSA is broadly written based on the 50 state statutes that require insurers to offer coverages for the medically necessary repair of congenital anomalies. It's important to the ectodermal dysplasias community because, as you can imagine, many of the treatments, including dentures or oral treatments, are not being covered even though they're medically necessary. So that's why our advocates are advocating for this legislation. The Ensuring Lasting Smiles Act will ensure that private, group, and individual health plans do not deny or delay medically necessary treatments of congenital anomalies. And it puts the determination of medical necessity in the treating physician's hands rather than in the insurance company's hands. So these are our fearless bill leads: Senator Tammy Baldwin of Wisconsin, Senator Joni Ernst of Iowa in the Senate, and then Representative Anna Eshoo from California, and Representative Drew Ferguson from Georgia, who is a dentist. So what will ELSA do? About 4% of children are born with a congenital anomaly. So ELSA will ensure that private, group, and individual health plans do not deny or delay medically necessary treatments of congenital anomalies. And just a few examples of congenital anomalies are oral defects, which I was just talking about: cleft lip, cleft palate, hypodontia, and enamel hypoplasia, skeletal defects, vision defects, hearing defects. But the bottom line is that any medically diagnosed congenital anomaly that requires medically necessary treatments would benefit from the passage of the Ensuring Lasting Smiles Act. And that's why, even though the NFED is leading this effort, we are working alongside 70 plus organizations that are supporting and advocating for ELSA. So your story is powerful. We believe that providers and researchers and patient stories go hand in hand. And when we raise our voices together, we're more powerful. Legislators want to hear stories from the patient's and provider's perspective, and you're the best person to share your story or your patient's story. We have the opportunity to help change the lives of many individuals, like our families who are living with congenital anomalies, and we need advocates representing many congenital anomalies to advocate. Personal stories or patient stories can help a legislator decide to co-sponsor or support this legislation. Time and time again, one family has been the deciding factor as to whether a certain senator or representative would sign on to support this legislation. Every single legislator is important at this point, and we are hoping to try to get this across the finish line through the Senate and passed before the end of the year. If legislators don't hear from you, they won't know how important this legislation is to your patient or your patient community. Anyone can advocate. It doesn't matter if you've done it before. So we're hoping that some of you will step up and make a difference in your state. So we're to the question and answer part. I just wanted to mention before we move to the next slide, here's my email address. There's a couple ways that you can help. You can ask your family, friends, and colleagues to advocate. You can take 2 minutes to send an email to your senators through the NFED web tool. We have that available on our webpage. You can also email me if you'd like a link sent to you. And then we also have a private Facebook group called the Ensuring Lasting Smiles Act Advocates private group on Facebook. And you can go in there to find any updates on ELSA. So our voices are stronger together, and we'd thank you for any support you have, or if you would be willing to advocate for ELSA.
Thank you so much, Becky and Mary. I actually have a question. With genetic testing being so readily available now and much more accessible, what are the barriers to diagnosing this condition?
You know, I would just like to comment and actually apologize to Shannon and Erin that I forgot to mention that AEC syndrome is often misdiagnosed as epidermolysis bullosa. So, you know, in answer to Jen's comment is that it just has to do with awareness. I mean, this group of conditions is rare. And even though there are some very characteristic clinical features, you know, it takes somebody who knows about this. So thanks to everybody who's attending today.
And don't you think that providers can go a long time with not ever seeing a patient? And so it's very hard to identify and really know the different syndromes. And some of the more mild syndromes, the symptoms can be subtle. And so for doctors and nurses, they may not really question so much.
Yeah, I think it's just familiarity. And, you know, again, for those of us who put the training into being a pediatric dermatologist, and even if you have, pediatric dermatology is getting to be a big field when there's a lot to know, especially about the rare conditions that we may only see, you know, once, if ever, in our career. So it really has to do with recognition. But the wonderful thing is having organizations like the NFED that, you know, once the inkling is there and the differential is formulated correctly, you know, then there's a place to reach out for management recommendations.
Elaine, I had a quick question for you. What made you volunteer with the National Foundation for Ectodermal Dysplasias, and would you encourage other researchers and providers to also volunteer their time for the NFED or another patient advocacy organization?
You know what, Becky, that is also a great question. And it was so long ago, and I apologize, Mary. I said 30 years, but, you know, like time goes so fast. 40 years, unbelievable. So then I probably have been, you know, participating. I'd still say it's been about 25 years, you know, because Nan Esterly preceded me for about 10. And Nan really asked me to get involved. You know, I think she was kind of ready to step back. And, you know, it was one of my career changing opportunities to participate. I feel incredibly privileged to have been, a small part of the organization. And so I would really encourage other people who are interested. And I also have been involved in other patient support and research support organizations. And I got to tell you, the NFED is my favorite. It's just run in such a way that has been, I don't think it's an accident that, that it's been so effective in promoting patient care and research. Just because the way the organization is run. And Mary Kay Richter, who's the founding mother of the NFED, I think she always thought that, there was an angel on her shoulder, and I believe her.
Well, I believe her too, Elaine. And I will just go on to say, we really can't do it without you. I mean, we need your expertise to help our families learn how to treat these very rare conditions and develop materials. And, the joy of seeing families at family conference, I know it has to be rewarding for our physicians and our experts, but for our families to have that expertise at their fingertips, you can't imagine the difference it makes in their lives when they can get answers that nobody else can give them. So we are so grateful for our professionals that volunteer so much time to help our mission.
And the NFED is really unique in knowing how to utilize the expertise of their volunteer clinicians. Other organizations that I've been involved with really don't have that magic touch, but for anybody who's interested, it is a win-win. You certainly can offer, some insight from, our dermatology perspective, but, what you get from it is, experiences that, are so unique, and, you can't get them anywhere else. It's been a real honor and a privilege.
We do have one question. Is it common for patients with ectodermal dysplasia to need an ophthalmology consultation?
We certainly do have ophthalmologists that are on our scientific advisory committee who've been, incredibly knowledgeable about, the dry eye situation, eyelash problems, and a whole variety of other, with ankyloblepharon, a whole variety of other ocular related conditions that it is again a win-win having, pediatric ophthalmology expertise in general, but putting that unique experience to work to consider the unique challenges for the ectodermal dysplasias. And then the other specialists for the attendees that, we have now, a really growing group of multi-specialists who are participating, ENT, ortho, ophthalmology, dermatology, OBGYN, help me out, Mary. There's so many now. It's just been a wealth of information and different perspectives, general pediatrics.
Genetics, genetic counselors.
Of course, dental.
Yeah, dental. They, both pediatric and prosthodontists. And I will also add that I think it's incredibly really important for these patients to see an ophthalmologist early on, because my understanding is, dry eyes can kind of creep up on you. And if it's not managed in the beginning, you can have some pretty significant complications from that. So thank you for that question. It's a really good one.
We have a question.
Can I add on to that? I apologize. Erin's corneal issues started while she was in the NICU. So even at just weeks old, like the oxygen was drying out her eyes, and then she ended up developing a corneal ulcer, which needed tarsorrhaphes and an amniotic membrane graft. So, like Mary said, early intervention is best.
And then we have a question for Erin. Is there anything that you want doctors or providers or researchers to know about ectodermal dysplasias in your journey with ectodermal dysplasias?
If you could say one thing about having ectodermal dysplasia to a doctor, what would it be?
Well, that it hurts a lot.
So it still hurts even though it looks healed? It still is uncomfortable sometimes?
Yeah, sometimes.
I have one question for Mary. if there is a researcher or provider on today who says, geez, I'd really love to help the ectodermal dysplasias community, but I just don't know where to start. What can they do, and who would they reach out to volunteer their time?
I would love to hear from them. Mary at nfed.org, or call our office 618-566-2020. We would love to have your help.
Everything from summarizing clinical recommendations to reviewing grants to attending the family conference and providing expertise. There's a lot of opportunity for clinicians to participate.
And then also I wanted to ask Shannon, do you have anything else that you wanted to add at all in regards to how important researchers are to the ectodermal dysplasias community, or what you would like to see out of the research community in terms of even Erin syndrome, or just the whole ectodermal dysplasias umbrella family?
So the research portion is very important to me. For future, and I wish there was more money and knowledge put into it, or awareness put into it prior, so Erin didn't have to go through what she went through with the severeness of the erosions particularly. But moving forward, I think that research is extremely important for future children, obviously, so they don't have to experience some of those traumatic and negative experiences that she had to.
Thank you, Shannon. And then we also have, sorry.
Can I just mention one thing? I really neglected to mention, probably the most exciting research that I've heard about in my entire career, and that's the work of Holmes Schneider, and now a multi-center international trial that is doing groundbreaking work in giving a molecule that was developed 20 years ago, probably, Mary. That's a ectodysplasia analog. But after going through trials in mouse models, knockout mouse models, and then in the dog model, now it's launching into human trials. Although there were single case trials where ectodysplasia was actually given to babies immediately after birth, and now starting in utero to correct the defect of hypohidrotic ectodermal dysplasia. And then, as I briefly mentioned, some very exciting work looking at wound healing for AEC syndrome in a molecularly directed way.
Thank you, Elaine. We have another question. Is it not peculiar that sebaceous hyperplasia is common when ectodermal derived structures are normally reduced in HED patients?
Absolutely, and I did mention that. And these people who have HED, men in particular, who tend to have a little bit more prominent sebaceous hyperplasia, I think, than females, but they don't really seem to get bad acne. They just have this sebaceous hyperplasia, and all I can think about it is that it must be sort of a reciprocal, reactive problem. These patients also have very thick cerumen and very thick nasal secretions, and maybe that just has to do with aberrant or, diminished, water secretion. I don't really understand that. There's so much that we don't know about, and so much room for doing investigation about these problems and, how to best address them.
I just want to also thanks, Elaine, for bringing up that really exciting research, the X-linked HED clinical trials. The first site opened in St. Louis at Washington University about a month or two ago, and there's plans to open a site on the West Coast and the East Coast. But anybody who has any ability to help us get the word out, that's going to be the big problem, is letting clinicians and potential patients know about this research, because it's going to be a tragedy if, a baby goes untreated that perhaps could have been treated. And the early results, or even not so early results of the therapy, the clinical trials, that we are learning that sweat glands can function normally. They develop more teeth. So it's pretty incredible, this in utero treatment. So thanks for bringing that up, Elaine.
No, I just wanted to come on and say thank you so much to the NFED and to Dr. Siegfried and to Shannon and Erin for this wealth of information. It's always really impactful when we can put patient advocacy organizations directly in front of our researchers, and I know how much they appreciate it. And I am just so happy that you were all so willing to do this. So thank you very much.
Thank you for having us. We really appreciate it. And we hope we'll hear from some of the participants as to how they can help the NFED community. Thank you all. Have a good night.
Thank you, everyone. Thank you so much for watching. If you have questions about the National Foundation for Ectodermal Dysplasias, feel free to reach out to either Mary or Becky. You can also learn more at nfed.org. You can find more educational programming on PeDRA's website at www.pedraresearch.org/education.